Do you want the truth? The whole truth? The ugly truth? Well, that's what we're going to discuss today, because there is no reason for these second lockdowns to be happening and no reason for the hospitalizations to be nearly as high as they are and no reason for the deaths around COVID to be as high as they are. Come on, everybody. Let's go find out what I'm talking about. Hi, everybody. This is Dr. Chris Martinson here with your Uncommon Sense show for October 29th, it looks like. We're calling this one The Ugly Truth. You're going to find out why in just a second. So let me get on over here. First, some good news around masks. There's an interesting study came out of Vanderbilt. Remember now, what we've been talking about with masks is principally around this idea of a lower viral load, also known as a lower inoculum. You get inoculated with virus particles and you get sick. And the theory is very simple. If you start with a lower load, you get less sick. All the animal models support that. All the data is coming in to support that. So this is another piece of data. What they did here, Vanderbilt University takes a look at Tennessee and looked at all the different counties in Tennessee, which each had sort of different mask requirements that they were imposing and enforcing. And so look, check this out. This looks at number of hospitals, the case count in hospitals in counties here where less than 25% of patients were from counties with a mask requirement. So under 25% of people were wearing masks in these counties. Look at this case count, went from no change to up over nearly 300% increase in hospitalizations. But how about in places where there was a 25 to 50% mask wearing adherence in the county? And you can see here, still 100% increase over July, but certainly a lot less than that. This makes a strong case that wearing masks reduces the amount of hospitalizations. It may not reduce the total spread of the disease because you would still get it. You would still catch SARS-2. You might still replicate it. You might even get COVID. But if you have a lower starting inoculum, then you get less sick. So this supports that. Well, what if we carry that on a little further? Here's what they went a little deeper, and they looked into comparing this now to counties where 51 to 75% of patients were from counties that had some sort of mask regulations and adherence to that. Look at this, almost no change from July. And how about in places, hospitals that are located in counties where over 75% of patients were from counties with mask requirements? And check this out, no change from July 1. So when we talk about all these second waves and all this illness and everything, we can prevent it at the front end just by wearing masks, okay? Because we get a lower inoculum. We as sick people spew out particles, we get fewer of them out because some of them get caught, especially the big ones that might carry a lot of viral load. And then on the way in, if we're the person getting infected, again, the mask helps us get a lower inoculum. All right, great data. Thanks, Vanderbilt. That looks pretty good. Just another reason to wear masks. Here you can see all that data side by side. Again, all the way on the left, these are hospitals that are filled up with patients where under 25% of patients were coming from counties with mask requirements. So they're coming from basically no mask requirements. And then to 50 to 75% on down the road. All right, check it out. This edition, though, I could have called this one French dummies. And I'm just going to pick on France here for a bit because they're being super dummies about this whole thing. I mean, just dummies. But no worse than the UK or the US. Together making a US, UK, you suck, if we acronym that out, you suck. So French dummies. France is about to impose another 4-week national lockdown. Just economy destroying kind of a moment there. And why are they doing that? Well, they're doing that because French infections are spiking again. They are way above what they detected back in that first bump way back there in March, April, May. By the way, they weren't really testing all that much back then, and so we don't know how to compare these two sizes of the bumps. But for sure, there's a big second wave of infections that are being detected. And notice I'm using the word infections here very carefully because they say cases. Read that title up there. It says, France, number of new coronavirus cases per day. Remember, these aren't cases. Cases are infections that require medical intervention or supervision in some way. To just simply get the disease, the SARS-CoV-2 virus, and to then have a detectable number of virus particles in you, but you're completely asymptomatic. Nothing ever happens. You don't even notice that you're sick at all. And that still counts as a case. It's not a case. Let's get our terminology squared away and keep that squared away. There are infections, there's cases, and we have to keep those really clean. All right. So now we can see it in a little bit better context, because here's how France is recording an increase in the number of coronavirus deaths per day. And so what they're really concerned about here in France is that their hospitals are starting to fill up and deaths are on the rise. So they say, bingo, therefore, we're going to need another lockdown. Kind of makes sense, except you have to be a dummy to go for that story. And here's why. First up, so France, COVID-19 Crusher, a great source of information still for me in this day and age over there on Twitter, says France is going to announce a form of national lockdown due to a fear of saturation of its hospital capacity. A good way to increase the hospital capacity is to increase the discharge velocity or rate. A large French observational study has shown that this thing that the drug that shall not be named, does just that. Look at this. Overall discharge rate when the drug that shall not be named. By the way, this is just that drug alone. No zinc, no azithromycin. Just it alone, which is okay. It's better than nothing, as we can see here, because this is nothing on this side over here. Let me get my little drawing tool out here. So on this column, we have this thing alone, 623 patients looking at in here. Neither drug, 3,792. The overall discharge rate was 58%. So they had a 58% discharge rate compared to a 40.7% discharge rate. Hey, France, you don't want to be a dummy and you want your hospitals to clear up. Increase the discharge rate. It's not hard. You do it right there. Look at that. That's an 18% improvement. That's tasty. And the 28% discharge rate was 56% versus 39%. So again, really strong data here, and it's statistically significant. So how about this? Don't be a dummy. Use something that works. Now, that's not what France did. France banned this drug that shall not be named back in, is that May? I think May, somewhere back there. And then recently, I believe they added it to its poison list, despite the fact that there's no recorded cases of anybody being poisoned by this, except in the UK recovery trial, where they gave toxic doses to people on purpose, which whole other story. We've covered that in the past. Ugly, ugly story. Hey, more stuff coming out about ivermectin as well. I think I can still say that here without running afoul of anything. But once this is really proven to be super effective, just watch. This is going to be a no-go word again, too, for reasons that are becoming more and more clear, I hope, to everybody, what this system is really about. And it's not about, I can tell you what it's not about. I'm not sure what it is about. I can tell you what it's not about. It's not about health, welfare, and preventing deaths. It has nothing to do with that. It has to do with other stuff. So this was a controlled, randomized clinical trial on using ivermectin, doxycycline, and in this COVID-19. This comes out of Baghdad, Iraq, randomized controlled trial. So this is what we've all been waiting for, right? Well, here it is. Not the biggest trial. I wish they'd gotten more patients in there because it left it a little underpowered, but still really strong signals popping out of here. So first is time to recovery. Are you listening, France? Because if that's what you're concerned about, is getting people out of the hospital, you want that time to recovery to shrink, right? Check this out. On the ivermectin doxycycline, the total was 10.61 days compared to 17.9. Wow, cuts a whole week off. That's amazing. P-value less than 0.0001. The trial was powered enough to give us a whopping P-value on this. But check it out here for mild and moderate. It's down to 6.34 compared to 13.66. Again, a whole week cut off of that experience. And for severe cases, 20.2 days compared to 24.2 days. So not statistically significant, but still 4 days is nothing to sneeze at. If they'd had more people in the trial, that probably would have been a significant finding as well. And then critical, note they didn't put anybody on control in the critical. They didn't feel, I guess, that was a moral thing to do. So when they had people come into the hospital who were in critical condition, they plunked them on the ivermectin doxy thing, and here they had 19.77 days to get out of there. I'm raising that idea that they only put people who are critical on ivermectin because when we get down to here for the disease progression and also mortality rate, let's jump right all the way to the bottom. Critical patients, 2 out of 11 or 18.2% died on ivermectin. They don't have any data to compare it against here in the controls because they didn't have any controls in that condition. So we can't really compare whether ivermectin prevented death or not in this case. But we have lots of other studies that say it does. So this is just confirming, piling on. This is roughing the passer after he's down on the ground, right? This is just continuing to add to this mountain of data that says, wow, this stuff not just works, but works great, works 10 times better than remdesivir ever could think of working. Now, carrying on, in the United States, Dr. Zelenko has been one of the most fierce advocates for hydroxychloroquine. He lives and works out of a county just north of New York City, treated a lot of patients, finally got one of his papers in publication here. It's in the International Journal of Antimicrobial Agents. It just came out recently on the 26th of October. And so this is zinc plus low-dose hydroxychloroquine and azithromycin. This is what we've been waiting for. This whole thing. It's still a retrospective case series studies. It's not a randomized controlled trial. So you know what the NIH is going to say, oh, we can't trust that because it doesn't pass through this little bar. And then you might ask, hey, NIH, when are you going to run your own RCT trial on hydroxychloroquine plus zinc plus azithromycin? The answer is never, or maybe we'll be done with one by next year sometime. Crazy that we're still at this part of the story. But by the way, I really probably shouldn't use that word anymore. That thing he used right there. So when I try and say the drug which shall not be named, that's the acronym down there. Drug which shall not be named. We'll call that DWSNBN. DWSNBN. Sounds almost vaguely Russian. DWSNBN. So let's talk about DWSNBN plus zinc plus azithromycin here real quick. All right, what happens is hospitalization rate declines enormously. Look at this. The hospitalization percent of people who are treated with DWSNBN plus hanging out around 3%, and it was up around 15% here for people who were untreated. Not the hugest study in the world, but pretty good sized, enough to give it power. So that was 377 in the treated group. So that's a good number. So as well, when we're looking at deaths here, this is all-cause deaths. So in the treated group with DWSNBN plus, very, very much lower number than this, like lots lower. Actually, this p-value, very statistically significant. So it's significantly lower deaths in patients treated with DWSNBN. So that's not surprising at all at this stage. What is surprising is that this isn't just being used as frontline treatment all over the world at this point in time. So Dr. Zelenko study, significantly fewer deaths. Here it is in table form, in case you like it that way. So hospitalization in the treated group, they had 4, which was 2.8% compared to the untreated group, which was 58. Very significant there. And all-cause death, 1 in this group compared to 13 in this other group. So the odds ratio hanging out at somewhere around 0.2, call it. So around an 80% reduction in hospitalization and death, leading us to suggest that DWSNBN works. So there's really no need for all this then, right? So look at this. I just pulled this up off of Google search. France sees highest number of COVID-19 patients. Hospitals closed to coronavirus. Europe's second wave is filling up the hospitals. France and Germany announced new restrictions as cases surge. Look at all this. It's this insane thing. But what do we do with this information? I don't know what to do with it, because when we use a variety of things, the DWSNBN, ivermectin, vitamin D, zinc, selenium, the doxies, there's things out there which take the hazard ratio and cut it from 1 down to 0.1 or 0.2 or somewhere in that zone. That obviously is going to be just a huge thing. So what's going on here? This is where we get to the ugly truth, because the ugly truth is that what is going on here has nothing to do with what's right, what's good, what's humane, what's caring, what's loving, what has to do with health. It's an ugly story that's going on right now. And that's a scientific opinion. Science melded to my opinion. In India just piled onto this whole story recently too, saying DWSNBN works as well. So this is looking at seroprevalence. So they're looking at the after effects of COVID exposure where people have circulating antibodies in their serum, the prevalence in the serum of antibodies to detect prior infections. Amongst healthcare workers, so this is from a major metropolitan hospital in a city from India, and so these are the most at-risk people in terms of getting exposed. And so what they found here, they looked at 1,122 healthcare workers. It's approximately 25% of the employees in this one hospital. The overall prevalence, seroprevalence, was 11.94%, so call it 12%. About 1 in 8 people had antibodies. By the way, that wouldn't include everybody who'd been exposed because not everybody develops antibodies. And so they also noted here that housekeeping staff, food and beverage staff, lab assistants, and technicians had higher seroprevalence than doctors and nurses with a p-value of 0.0001. Highly, highly, highly significant. And healthcare workers with a history of BCG vaccination, that's the one for tuberculosis. So a lot of people in India get that vaccination. So if they had that in childhood, and those who received an adequate prophylactic dose of Duisenbin had a lower seroprevalence compared to those who did not. So it was 7.31% versus 16.8%, and 1.3% versus 11.25%, respectively. So just the BCG vaccination cut the risk way down, meaning that if you've had that vaccination in the past, your immune system's tuned in a way that when you get exposed to SARS-CoV-2, you don't develop COVID, you don't develop antibodies. So that's the theory right there. We'll be chasing that one down in the future. But if you had both the BCG plus the Duisenbin, you then had a 1.3% versus 11.25% chance of having circulating antibodies as a consequence of exposure to SARS-CoV-2. Wow, that's amazing. That's huge. That's gigantic, enormously significant. Did you read about it in your newspaper today? Probably not. You probably read about how you need to be afraid. You probably heard on the news about these second waves that are just terrorizing everything and how the whole economy is going to have to go into lockdown and businesses are going to be destroyed and all of that. And none of that is actually necessary. Not if we use actual science. So this is a war on sense making that's happening right now. You can't make sense of this stuff on your own and square it up with what you're hearing and reading in most places in the mainstream news. Just, you can't do it. Harvey Risch is a Yale epidemiologist. He talked about FDA obstruction, that patients are dying, and the media is busy blaming Trump for stuff. But the FDA has a very, very strong role in creating the condition that's happening in the United States. And as he pointed out here, it was on July 1st that the FDA posted on its website a large black letter warning against using Duisenbin to treat outpatients. So this is a big deal. So once people get into the hospital, if you begin to treat them, it's often kind of late. And the later you treat them with Duisenbin, the less the effect of this thing. The best place to use it is as early as possible, as India just showed, prophylactically, even before people get exposed. That helps limit the exposure and the subsequent development of any sort of disease. So for the FDA to have come out and said that they cautions against the use of Duisenbin or the other variant of it for COVID-19 outside of the hospital setting means we don't want you using it on the outpatient setting where it would do the most good, where honestly they would know that. I mean, we all knew that. We've known that. We've known that since early in 2020. They clearly would know that by July. So the FDA specifically said, we don't want you using it where it could do the most good. Full stop. That's just awful. There's really no way to say it except that burn it down. Burn that facility down. Just start all over again. Whatever toxicity is going on inside the FDA that allowed them to make that decision at that time was indefensible on every moral and ethical ground I can possibly come up with, but certainly a scientific and a medical ground. There's no grounding for that. They say, oh, well, it's so dangerous. Nobody knows where that whole dangerous meme came from because there was no data around that. And so Harvey Risch mentioned, and finally, the FDA does not mention that it has no data showing adverse events in outpatient use. And by the way, I forgot to mention that in the Zelenko study, they had 0 adverse events that were worth reporting, no cardiac events. In fact, there have been none reported. People get a little nauseous. Certainly if you give too much in toxic doses, they get more nauseous, and there's other things like that. But there are no adverse events. Nothing where you would say, this is so bad, we have to pull this thing off the market right away, because the benefit of using it against COVID is so much outweighed by the terrible toxicity of this compound. This is one of the safest compounds. It's been used for 70 years, billions of doses. And we literally have 0 reported sudden cardiac arrest as a consequence of that. And still don't. And yet the FDA came out and said, this is so dangerous, we're going to black letter this thing and we're going to take it off for outpatient use. You can still use it in hospitals, but they really preferentially wanted it to be used as late as possible so that it wouldn't work. That's BS right there. Full on, full stop. All right, hey, you French dummies, talking to you, France. Now, if you really wanted your hospital rates to go down and you're concerned about that, and you didn't want to shut your whole economy down, you could wear masks, you could use DWSNBN, you could use ivermectin, you could use or supply vitamin D, zinc, selenium. If you did that, your overall mortality rates would be cut drastically, and the overall hospitalization rates would both go down, and the durations of stay would shorten up big time. Why are you not doing this? Does anybody have a good explanation for this? I don't have good ones. I got bad ones. I keep mentioning that. I don't have any good ones. But this is no longer about health. It's no longer about what's right, what's good, what's proper. It's very hard to maintain a sense of faith in the system when the system is doing everything it can to run a script that doesn't make any sense to ordinary people like us. You know, people who have empathy, compassion, are capable of love, concern, all of that. I can't explain this. It's really not good. So at any rate, just as a reminder, I talked about a lot of this too in the weekend seminar that we just had very recently. So I'll point you back to that again if you're interested in that. I also put out much of my very specific recommendations in there about the exact regimen that I would be following should I get sick, if I want to avoid getting sick, and if I indeed develop COVID, some things I would do. Great to see more and more doctors are actually piling in and getting this right, and there's some great stuff out there to look at. So France, UK, US, NIH, FDA. Here's the deal. It's impossible for them to be unaware of these treatments and unaware of the significance of these hazard ratio reductions and unaware of the significance of the significant findings. It's completely impossible for that to be the case. So, as Arthur Conan Doyle said, once you eliminate the impossible, whatever remains, no matter how improbable, must be the truth. So you decide for yourself what you think that truth is. I don't actually know what they're doing, but I can tell you what these countries and these health managers are doing has nothing to do with limiting disease progression, limiting and informing people, limiting the spread of disease by informing people, and giving people the actionable context information that they need to make decisions in their own lives about how to keep themselves safe. They're not doing that. I'm doing that. A few other people out there are doing that. But by and large, the machinery of the system is really geared towards telling you to be afraid, hunker down, wait for a big daddy vaccine to come along and save you or something like that. And my advice to you is ignore all that as best you can. Just trust yourself. That's it. Trust yourself. Follow the links I provide with every one of these episodes. Read the studies for yourself. Educate yourself. Inform yourself. Make your own decision, because we're at this part of the story where you have to begin making sense of things for yourself. That if it's impossible to make sense out of nonsense, right? So don't try. Don't even try. You know, when the papers are telling you, oh my God, I probably went through 40 articles this morning trying to find some actual data on France's actual hospital capacity utilization rates right now. And nearly all those articles just mentioned that they were filling up. I get that, but it doesn't have to be that way. And also, that's just fear mongering. So ask yourself and trust yourself. You know, the question is, why am I being fear mongered to? By whom and for what purpose? I don't have answers for that, but I want you to trust yourself when it comes to your own health. Do not listen to these goofballs who have no answers and can't seem to process simple information, but yet keep bringing you bad information, like take remdesivir. It's awful data. That's just terrible. It's awful. All right, that's all I got for today. Hey, have a great weekend. We'll see you next time.